So I'll quickly go through the first year of this infection. This was in 2019. Okay, so 54-year-old woman, diabetes, adult ischemic spondylolisthesis, gets this surgery. It's difficult to tell exactly what time frame, but gets a wound wash twice. Now this is all happening at a different hospital. So I don't have all the details, but there were a couple of wound washes. Obviously the initial attempt was to retain the implants, and then there was a whack afterwards, and the subsequently over time the wound was allowed to heal with a secondary intention with the whack, and chronic suppressive antibiotics were given for a very long time. And over this whole course of a year, at different points in time, Pseudomonas klebsiella E. coli grew in the wound. She was treated with ceftriaxone sulbactam, which is the Ilores that sir said. It's for 8 months, Septran for 6 months, fosfomycin 1 gram for 1 month. She got colistin 16 doses but developed nephropathy, so it was stopped. But overall a very prolonged course. In the last 2 months, so this was the MRI, 6 months post-surgery, shows quite a bit of osteomyelitis infection, and that X-ray which I showed was approximately at this time. The implants were starting to lose out at this point in time, but the patient was a walker at this point. Towards the end, last 2 months, she became bedridden because of more severe back pain. Obviously, the implants had loosened out. She had quite a bit of weight loss. CRP was in 40-60 range at different points in time. Hemoglobin had come down quite a bit. UTI, because she was a catheter for about a year. For some reason, the catheter was kept on and developed Klebsiella UTI, which was colistin sensitive at that point. Now, this is the MRI which she presented. She had already the loosening of implants, but you can see the infection has extended in the upper part of the lumbar spine, and the marrow in the area of the surgery has reverted back to normal. So you can see that at L4, L5 and S1, the marrow has changed, but the infection has extended into the upper lumbar regions. These are the actual images. You can see the paraspinal abscesses in the upper lumbar regions, but not so much in the lower. This was the wound at 1 year. So what we did is we first did a posterior, debrided the whole thing. We couldn't get to the cage from the back. The cage had slipped quite a bit anterior, and this was the wound. So thorough debridement of all the infected part from the back, whatever was visible. Those are stimulant beads with colistin, and then a plastic surgery closure was done with releases and fascia releases, and also we could get a posterior closure at this point. And this was the post-operative X-ray. So we allowed for the wound to heal, and the idea was she was a sick patient by now. She was in sepsis, so we couldn't do an anterior posterior just at one go. So after about a month's time, we took her back again for an anterior part of the debridement, and the anterior part we could debride, but we couldn't get to the cage in the front at the L5S1. Obviously, this wouldn't be the right position to get to the L5S1 cage, but it was very difficult, so we didn't even attempt to get that. But the wound just refused to heal. She kept pouring pus at the back. Now, at this time, she has CRE, completely carbapenem resistant organisms. Only colistin was being given, but she was struggling with all the complications because of colistin. At the last point in time, she had this kind of an infection, just couldn't come under control. The infection kept spreading up and up in the upper lumbar spine. Eventually, she died approximately 6 months post-surgery. So, the lessons learned from this case was the initial part of the debridement, especially the T-lift, should have gone the way Dr. ZAVERI did, remove all the implants, especially the cage. There was initially quite a bit of delay. allowing the wound to heal. And by the time it was detected, the implants were loose. That's the time everything should have come out, including the cage, because the cage was a peak cage. Biofilm has already formed. The infection keeps festering inside. And if you use chronic antibiotics in such kind of a setting, you develop more and more resistance. So as just a summary for all these last two cases, for adults with interbody cage who have infections, disc space infections, you see whether the implants are secure or implants are loose. If the implants are loose, basically everything needs to come out, including the cage. But if the implants are secure and if the infection is early, before the biofilm has already kind of taken a hold, at that time you have an opportunity to do what we call as a DARE, where we try to keep the implants, salvage the implants, do debridements, wax as necessary. And if that doesn't work, then it goes to everything out. But if the implants have been there, if the infection has been there for more than a month, then this biofilm has already taken hold. And if the infection is around the cage, especially a peak cage, it is very difficult for this kind of an infection to be eradicated. And that requires very aggressive debridement to salvage. So this is an instrumented fusion which was salvaged with wax. This is Dr. Zaveri's case, same one which he showed, where is an example of an infection in the disc which was salvaged by removing all the implants. And this patient unfortunately couldn't be saved. Thank you very much.
What is your take on replacing implants? Suppose your screw is loose.
Yes.
When you open up, but TLIF is a very easy decision.
Right.
Because TLIF is not a very unstable situation. But sometimes we do it for, say, osteoporotic vertebral fracture. You put in a mesh cage in the front. Now your infection is there. Now you are afraid to remove the anterior cage. So how do you deal with that kind of a situation? Do you actually, when you come out at the back, the implants are actually loose. Do you replace them with fresh implants? Do you change the type? Because do you put a hard shield with sublaminar instead of doing a fixation again into those pedicle screws? What is the plan?
No hard shield. Hard shield is stainless steel, so with infection, stainless steel is not a good implant to put. Yes, if it is for osteoporotic spine, thoracolumbar spine, and it's a deep infection, and the implants are infected, including the anterior column is infected, then you will have to do a full debridement. Especially when once biofilm is formed and everything has taken a hold, then doing a half-hearted posterior debridement will not serve the purpose. And fortunately with us, we have Dr. Agashe and Aditya with us. And whenever we have infections, we take them along for the surgery. And the kind of debridements they do, we by ourselves will not. We just I kind of tell them that this area you cannot touch. That's the dura. You can do whatever rest you want. This is not the area that you would debride. And then they go berserk inside. They have to remove everything, all the infected material, front, back, and then replace it, obviously, because the column integrity is compromised. But the infected implants are the one with biofilm, so you need to get them out.